This first article comes from the Korean Journal of Radiology. Recent evidence has shown that reduction of abdominal and pelvic CT dose can be reduced to 2 millisieverts for diagnosing appendicitis without negative ramifications, but widespread use of low-dose CT for appendicitis has been slow. This study postulates that one reason low-dose CT is not caught on is due to autonomous overnight reads from residents in many academic centers who may not be experienced with low-dose CT. Previous studies, however, have shown that discrepancy rates between resident and attending reads are less than 3%. This study aims to compare residents' diagnostic performance and clinical outcomes for appendicitis using 2 millisievert or low-dose CT versus conventional dose CT. 107 radiology resident readers participated in the trial via daily practice after online training for low-dose CT. The residents' reports were finalized by attendings, and the diagnostic performance of the residents, discrepancies between preliminary and finalized attending reports, and clinical outcomes between the two groups was compared. The authors found that performance and clinical outcomes were not significantly different between the low-dose and conventional dose CT groups following radiology resident CT readings, indicating that low-dose CT can be utilized by radiologists at all levels for suspected appendicitis. This next article comes from the Journal of European Radiology. Due to high morbidity, the question has been raised as to whether some patients with rectal cancer are overtreated with total mesorectal excision. Watching and waiting is an emerging strategy for rectal cancer following neoadjuvant treatment, but selecting appropriate patients remains a challenge. This study aims to measure the accuracy of MRI in assessing rectal cancer response, as prior studies had small number of radiologists participate and did not report inter-reader variability. 12 radiologists from 8 institutions assessed baseline and restaging MRI scans of 39 patients with rectal cancer. They were asked to assess MRI features and to categorize the overall response to treatment as complete or incomplete. Overall accuracy was 64%, with a sensitivity of 65% for detecting complete response and specificity of 63% for detecting residual tumor. Interpretation of the overall response is more accurate than the interpretation of any individual feature. For most patients, variability and accuracy were inversely correlated. The authors conclude that based on this data, MRI-based evaluation of response at restaging is insufficiently accurate and has substantial interpretation variability. Some patients' response to treatment may be easily recognizable on MRI. However, this does not seem to be the case for most patients. Our next article is a review article from the Journal of Pediatric Radiology. Necrotizing enterocolitis is a common neonatal condition, especially in premature infants. Diagnosis of necrotizing enterocolitis has traditionally relied on radiographic findings and clinical presentation. However, ultrasound has gained traction in aiding in the management of necrotizing enterocolitis. Abdominal radiography, considered the gold standard imaging for NEC, may demonstrate fixed dilated loops of bowel, pneumatosis, free intraperitoneal air, and portal venous gas, but sensitivity is low, commonly resulting in equivocal abdominal radiographs. Ultrasound has been found to be more sensitive with less inter-reader variability than X-ray. Generally, a high-frequency transducer is used along with color Doppler for improved identification of mobile bowel gas and peristalsis. Early-stage ultrasound findings of NEC include bowel distension, hypervascularity, and echogenic mucosa. Later, bowel wall thickening, loss of gut signature, and loss of bowel wall distinctness may occur. However, thinning of the bowel wall to less than 1 millimeter may indicate a higher risk of perforation for which focal fluid collections, complex ascites, or free intraperitoneal gas may be signs. Portal venous gas is sometimes seen as mobile echogenic foci in the main portal vein and branches, or as shadowing echogenic foci in the peripheral liver parenchyma. The limitations of ultrasound are shadowing from bowel gas obscuring deep structures, vibratory motion from ventilators, and decreased bowel perfusion in infants with low cardiac output or vasoconstrictive medications. Ultrasound findings associated with worse clinical outcomes are pneumoperitoneum, complex focal fluid collections, and complex free fluid, while increased bowel perfusion and anechoic free fluid are low-risk findings. The authors conclude that abdominal ultrasound can be a useful adjunct in the assessment of NEC in conjunction with clinical findings and abdominal radiograph findings. Our next article comes from the Journal of European Radiology. Computed tomography colonography, or CTC, is an effective test for colorectal cancer, or CRC, in average-risk individuals, with a higher reported participation rate than endoscopic colonoscopy. One of patients' most frequent reasons for non-adherence to screening programs is related to bowel prep, so a benefit of CTC is the use of a reduced bowel prep. Currently, diet restriction along with bowel prep is standard prior to CTC. This study aims to evaluate if an adequate bowel prep can be achieved without diet restriction, along with reduced amount of cathartic agent and fecal tagging. 1,446 patients undergoing elective CT colonography were used for the study. These patients all had the same bowel prep with reduced cathartic agent the day prior to the exam and a fecal tagging agent the day of the exam without any dietary restriction. Adequacy of bowel prep was evaluated using qualitative and quantitative scores. Patients' compliance was also evaluated with a questionnaire after the exam. The authors found that adequate bowel prep was demonstrated in 93.29% of patients. They also found great patient compliance with the screening test, with 96.5% saying they would be willing to repeat the process in the future. The authors conclude that lack of diet restriction does not affect CTC quality, and favorable patient compliance could potentially increase the participation rate in CRC screening programs. This last study comes from the Journal of Emergency Radiology. Multiple studies have shown a reduced amount of emergency department visits during the COVID-19 pandemic and lockdown. The authors assert that it is reasonable to think that during the pandemic, people avoided the ED to the point where their condition, such as acute appendicitis or diverticulitis, progressed to the point that it became more serious than during a pre-pandemic context. This study investigates the effect of the COVID-19 lockdown on adult ED visits, abdominal CT scans, and the presentations of appendicitis and diverticulitis in St. John's, Newfoundland, and Labrador. This retrospective analysis compared the numbers of patients presenting to the ED and abdominal CT reports, including the terms appendicitis and diverticulitis, during the pre-lockdown, lockdown, and post-lockdown timeframes. Daily visits during the lockdown showed a significant decrease in patient volumes compared to pre-lockdown. During lockdown, abdominal CT scans did not drop in proportion to the patient volume. The pandemic lockdown had no effect on appendicitis presentations, while diverticulitis presentations likely decreased. There was no increase in complicated cases of appendicitis or diverticulitis during the lockdown. The authors acknowledged that due to multiple factors, the population and infection rates of Newfoundland and Labrador differed significantly from other countries, such as the United States, which may limit the generalizability of this study.